good morning to all the delegates, my co-speaker, my chairpersons. As rightly pointed by the chairperson, OSA, obstructive sleep apnea, is a very common problem but also commonly missed. And as far as cardiologists are concerned, it's a mixed specialty. Hypertension, resistant hypertension, one of the main causes of resistant hypertension is an obstructive sleep apnea. It can lead to congestive heart failure, it can lead to increased atherosclerosis, a number of cardiovascular complications, arrhythmias, which can be occurred because of obstructive sleep apnea. One of the famous personality who has died of OSA recently, you can recognize, this is Bappi Da or Bappi Lahiri, the famous composer, singer, producer, director. He died of obstructive sleep apnea, which was missed. It is very common. If you take the criteria of apnea hypopnea index more than 5, 25% of the men and 9% of the women, they suffer from this population. Just to give you a rough idea, in a single coach in India, 15 people snore in a single coach of 64. So how common is this problem in Indian scenario? What is obstructive sleep apnea? This is characterized by repeated pharyngeal collapse in sleep, resulting in cyclic hypoxia, sympathetic stimulation, and release of stress hormones. Cessation of airflow for more than 10 seconds, despite continuing ventilatory effort, is one of the main criteria. 5 or more episodes per hour of sleep, that we call as AHI index, apnea hypopnea index. 5 episodes at least for 1 hour is mandatory for diagnosis, and it is usually associated with a decrease of more than 4% in the oxyhemoglobin saturation. What actually happens in OSA? Normally what happens is, during the sleep, the upper oropharyngeal muscles usually contract, which control the tongue and soft palate to keep the airway open. But if these muscles relax, the airway narrows, causing snoring and breathing difficulties. And if these muscles relax to a greater extent, the airway completely blocks or collapses and prevents the breathing and cause hypoapnea or apnea. What are the clinical features of obstructive sleep apnea? The predominant daytime symptom is excessive daytime sleepiness. These people sleep anywhere. They sleep in the coach, they sleep in the meeting, they sleep in the movies. But whenever they get time, whenever they sit, they go to sleep. So excessive daytime sleepiness is one of the main daytime symptoms of OSA. Other symptoms are cognitive and memory impairment. They keep on forgetting things. Executive dysfunction. They are not able to perform their duties perfectly. They are not getting promotions because they are not performing to the full capacity. Erectile dysfunction, sexual dysfunction is very common. Among the GI symptoms, gastroesophageal reflux is very common. Morning headaches, bilateral morning headaches is also very common in these OSA because their sleep is disturbed. They're not able to get a good sleep. I told you, they go to sleep whenever they sit. What are nocturnal symptoms or sleep symptoms? Loud snoring. Notice the very loud snoring is one of the predominant symptoms of obstructive sleep apnea. Choking sensation. During the sleep, they suddenly wake up, the airway collapse, and they feel a choking, and they suddenly, which cause arousal. Observed episode of breathing cessation during sleep, and abrupt awakening accompanied by shortness of breath. They are sleeping, suddenly they awake because of apnea. Sometimes these symptoms are mistaken as PND, presumed nocturnal dyspnea. So they consider cardiologists, they do their cardiac evaluation for that. But ultimately what is happening is, it is a complete collapse of the airway, which is leading to choking, which is causing the arousal, which sometimes is being mistaken as PND. Awakening with dry mouth or sore throat, and difficult staying asleep, insomnia. They're not able to get a good sleep. In spite of sleeping every time, they feel they are not getting a good sleep. And nocturnal polyuria. It is also very common. And restless sleep. So these are the cardinal nocturnal symptoms of OSA. Loud snoring is the predominant symptoms. The partner may complain that he snores so loud that I'm not able to sleep also. This is a posture taken in the case of severe sleep apnea. Posture taken while sleeping by a severe sleep apneic patient. In this posture, snoring may not be heard. So this is done to prevent the airway collapse, this type of posture. On examination, you may sometimes found a macroglossia, the tongue swollen because of this hypercapnia. The patient has a habit of sleeping with his palm on the cheek, so you may get pigmentation of the cheek because of the palm all the time on the cheek. So if we say about the cardinal symptoms, loud snoring and excessive daytime sleepiness, these are the two cardinal symptoms. Complications occur because of hypoxemia, hypercapnia, and cor pulmonale. So what are the risk factors for OSA? The non-modifiable risk factor, age itself is a risk factor. The higher the age, more is the chance of OSA. Male gender is more predominant than female gender. In ethnicity, being black and Hispanic have more tendency of OSA. Anatomical abnormalities of craniofacial region and upper airway, which is causing the airway to shorten, are one of the non-modifiable risk factor. A neck circumference, a thick neck with a circumference of more than 17 inch is a risk factor for OSA. And genetic predisposition, suppose a family history of OSA will have the children will have a more tendency of having OSA if the parents have an OSA. Just if the neck circumference is more than 17 inch, this is one of the risk factors for OSA. Anatomical abnormalities like retrogonathic profile, narrow airway passage because of the thin mandible, this is one of the, again, the non-modifiable risk factor. What are modifiable risk factor? Number one modifiable risk factor is obesity. Obesity is a major risk factor which predisposes these patients to OSA. Other risk factors are chronic consumption of alcohol, sedatives or tranquilizers, a narrowed airway because of enlarged tonsils or adenoids, chronic smoking, chronic nasal congestion. Hypertension is a risk factor as well as a consequence of OSA. Diabetes mellitus again is a risk factor as well as a consequence of OSA. And post-menopause or menopause is also one of the risk factors. Aggravating factors for OSA are sleep deprivation, sedatives, alcohol, supine posture, and use of tobacco. These are aggravating factors for OSA. And obesity and OSA, it's like a chicken and egg story. Obesity can lead to fat deposition in the upper airway lumen, which cause reduced tracheal contraction, oval types of upper airway shape, fat deposition in the upper airway muscles, which leads to OSA. Once there's an OSA, it causes reduced physical activity, it causes increased insulin resistance, it increases the ghrelin levels of hormone, which leads to obesity. So obesity causes OSA, OSA causes obesity. So it's like a chicken-egg story. What are comorbid conditions which are seen most oftenly with OSA? Hypothyroid, again, is a very common condition which is seen along with the OSA. Acromegaly, diabetes mellitus, hypertension, coronary artery disease, myocardial infarctions, congestive heart failure, stroke, chronic renal failure. In fact, one of the causes of resistant hypertension is OSA. We have seen we are treating OSA with CPAP, the blood pressure comes to normal. So one of the causes of resistant hypertension is OSA. One of the causes of uncontrolled blood sugar is OSA. One of the causes of comorbid condition hypothyroidism is OSA. One of the causes of precipitation of heart failure is OSA. To diagnose, the diagnostic of OSA is polysomnography, in which we do a proper sleep. We see for the apnea, we see for the hypoapnea, we see for the oxygen saturation, we see for the arousal, we see for how the muscles, abdominal muscles are moving. We maintain the EEG. Multiple things have been done to see for the OSA. The diagnostic is if there's a complete cessation of the airway for at least more than 10 seconds, with a drop in the oxygen level and arousal form, this makes a diagnosis of OSA. This is how the sleep study is done. Multiple parameters are assessed. We see the EEG, we see the airflow, we see the effort rib cage, we see the effort abdomen, we see the effort esophageal pressure, we mark the oxygen saturation. So number of parameters are assessed and then the report is generated. We can classify OSA into 3 categories based on apnea-hypoapnea index. If the apnea-hypoapnea index is more than 5 but less than 15, we call as mild. If it is between 15 to 30, we call as moderate. And if the hypoapnea index is more than 30, with the lowest oxygen saturation, which was recorded as less than 50, we call it severe OSA. How do we calculate AHI? We measured the number of apnea-hypoapnea index and the total hours of sleep and divide. If it is more than 5, it makes a diagnosis of OSA. What is the consequence of OSA? Untreated. It can lead to resistant hypertension. It can lead to heart failure. It can lead to various cerebrovascular complications, pulmonary artery hypertensions, various types of arrhythmias. It can lead to insulin resistance. It can lead to metabolic syndrome and neurocognitive sequelae. Particular vehicle accidents, these are very common. If the driver is suffering from OSA, he can fall to sleep anytime and can lead to major motor vehicle accidents. How do we treat OSAs? First of all, general measures. And the most important is to control hypothyroidism, control obesity, avoid alcohol, sedatives, avoid asking patients to sleep not supine posture but side posture. But the crux of treatment is CPAP, continuous positive airway pressure. It works like a pneumatic splint, mechanical effects. It increases the intraluminal airway pressure above the positive critical transmural pressure of the pharynx and hypopharynx. It pushes the tongue and soft palate forward away from the posterior pharyngeal wall. If it is done, it can reverse the consequences, reversal of symptoms, organ dysfunction, proteinuria, and personal observations have been seen. This is just how the CPAP is being done on the patient. How CPAP helps? In obstructive sleep apnea, we can see the closed upper airway. Snoring, there's a partial closure which causes snoring, and complete closure causes apnea. In CPAP, you can see the opening of the upper airway because of the positive pressure which has been generated. It prevents the collapse of the tongue and maintains the tone of the muscles. In clinical practice, it is found to be very efficacious. It is very useful, as I have told you, in resistant hypertension. If the OSA is the cause of resistant hypertension, if treating that can lead to blood pressure becoming the normal. It has a beneficial effects also in type 2 diabetes, ischemic heart disease, CHF in stroke, in dementia, improving neurocognitive functions. 1 minute more. Useful in Parkinson's patients who have OSA. Various types of CPAP devices are available. The benefit, I'll just finish it. There are few surgical techniques also, but the results is not so approved. Still, I say the best treatment is CPAP. In the 2 slides, I'll just give you a very beautiful poetic voice of a subject who's suffering with OSA. Can't sleep to the core. I know it's a snore. The snore is the alarm beep. People around me can't sleep. It stops for some time to recur again. Oxygen required again and again. Not only I disturb all people around, I too get up to visit the urinal around. Too tired in the day, inactive and depressed, constantly looking around for a place to rest. Snoring is a signal, a warning. Diabetes may be striking. Year pass by, I continue to snore. Hyperglycemia in spite of OHA more and more. May require insulin is the fear. Polysomnography is the answer. Diagnosis of OSA and application of CPAP, restful sleep, good morning, clap, clap, clap. Normoglycemia achieved, it is to be believed. Feel fit, fresh, active all the day without a gap. The night is welcome, but not without the CPAP. Thank you.